All right, welcome everyone. My name is Renée Deehan. I am the Vice President of Science and Artificial Intelligence at InsideTracker. And today I will be the host of our Women's Healthspan Roundtable. Let me introduce our very esteemed guests. We'll start with Dr. Gabrielle Lyon. She practices functional medicine and is the founder of the Institute for Muscle-Centric Medicine. Dr. Lyon is a nationally recognized speaker and also has a successful podcast that we sponsor. Dr. Sara Gottfried is a practitioner of precision, functional, and integrative medicine. She's the director of precision medicine at Thomas Jefferson University Hospital, as well as a 4-time New York Times bestselling author. Dr. Emily Lau is a cardiologist and investigator at Massachusetts General Hospital, an instructor in medicine at Harvard Medical School, specializing in women's cardiovascular health. Dr. Julia Serano is a biologist, musician, spoken word performer, and trans-bi activist, and also an acclaimed author of 5 books. So, thank you everybody for joining us. Today we will be discussing a range of topics related to women's healthspan. And really this conversation is for anyone that identifies as a woman, for people with ovaries, or for whom take exogenous estradiol or related hormones, and anyone else really who is interested in learning more about the topic, even if it does not directly apply to you. You are all welcome here. But first we want to set the stage and define the term health span, which typically refers to the duration of life spent in good health without chronic diseases or age-related disorders. Healthspan supports the maintenance of both health and functional capacity, that is the ability to perform activities of daily living. But at InsideTracker, a critical component of Healthspan is expanding the number of years that you spend in good health doing the things that you love to do. So this includes measuring your health metrics and taking actionable steps to improve those metrics and then assessing them over time. It's very important for us to differentiate the term healthspan from lifespan or longevity, because those terms really only take into account the number of years that you're alive and do not actually address the quality of those years. So let's just dive right in. This is a Women's Healthspan Roundtable, and I would love to ask each of you to talk a little bit about the underrepresentation of women in healthcare research and the impact that it has had on all of us. So I don't know, who would like to start?
I can start. So I feel like we have been at the short end of the stick for such a long time. And you could take as an example the use of hormone therapy in women. So we had 59 years of what I would consider to be an uncontrolled medical experiment done on women, where we used hormone therapy without a randomized trial to support it. So we face both biological differences, but also gender differences. And it has resulted in being female really it's a health hazard.
That's great. I fully agree, it is a health hazard. Dr. Lyon?
Yeah, I think one of the things that I think about in terms of underrepresentation of women is more from my perspective as it relates to skeletal muscle health, is that oftentimes when we think about health and wellness, women are often encouraged to do things that perhaps don't optimize skeletal health, whether it's weightlifting, although maybe now it's starting to turn around. But the majority of the time from the patients that I see, they're afraid to get bulky. The information that they've been told, they're much more likely to say, okay, well, I want to do a Pilates class, or I want to do a class that, because I don't want to get too big. Yeah. Not saying that there's anything wrong with Pilates or any of these other modalities, but I think women have been taught and told things that have created unnecessary fears that ultimately, especially as women go through menopause, destroy their health.
And if I can add a perspective from the cardiovascular angle, we're very lucky in cardiology to have so many randomized trials to guide our treatments, but women make up the minority of clinical trial participants. And this is something that has not changed. Even now in 2023, women really make up no more than 25% of the total number of patients who are in clinical trials. And yet we take these clinical trial results and then we translate this to clinical care. But women are not little men, but that's what we're doing, sort of in our clinical practice.
Absolutely.
Yeah, I think it's really important to tie all of this together with the lack of representation of women and also other minority groups within science, within STEM, within healthcare. And one of the things that I often think about, because it's sometimes a difficult subject to broach because everybody wants to believe, oh, well, I'm not prejudiced, I'm not sexist, I'm not discriminating against people. And a lot of that is happening at underlying levels. There are a lot of assumptions and expectations and norms that we've all internalized that we sort of expect people to behave particular ways, and we perceive them in different ways. And one story that I remember very vividly when there were debates about women in STEM and the underrepresentation back in the mid-2000s, there was a neuroscientist named Ben Bars, who he would give this story to talk about perception, and it was he was a trans man, transitioned from female to male mid-career, and one time when he was giving a talk after he transitioned, somebody in the audience said to a colleague, well, you know, Ben's really good, he's much better than his sister. And he doesn't have a sister. And that was all perception. And so I think it's really important to address that as well for women and also for other minority groups, because nobody's going to ask certain questions if there are people in the room who have some insight that aren't there to do that.
110%, and that's why it is like so critical to have that representation in STEM and definitely in medicine. Because I think we were talking earlier, of course, you know, sometimes you may want to see a physician that looks like you or understands who you are and the things that you're dealing with. So, you know, we'll also jump into healthspan here, and I would love to hear from everybody. What do we not know about women's healthspan that we absolutely should have known decades ago, that you're just chomping at the bit for us to understand?
Please go ahead.
Please go ahead.
No, I was really going to say that as a cardiologist, you know, we know that women really don't develop heart disease until about 10 years after men do, and that the rates of heart disease really start to accelerate after that menopause transition. But we don't know anything about why that is happening, despite years and years of hormone therapy, to your point earlier. And so this is a huge unmet clinical need.
I would say one of the things that's of critical importance, again, is we think about body composition. That is of the utmost importance. And you know, what I see is this hyper focus on obesity, and especially as it relates to women. You know, they're constantly being told, or at least the messages that they're getting in the media is, we should lose weight, we need to lose fat. What ends up being critical is that obesity is a symptom of unhealthy skeletal muscle. Being able to understand, as it relates to women's health, that you have to develop and train and build this base foundation of skeletal muscle health throughout your life. If you really want to think about health span and all these other things, you know, we talk about cardiovascular health, we talk about heart, you know, thyroid health, all these other organ systems, but we very rarely focus on skeletal muscle as an organ system, which does need to be leveraged, and you know, particularly for women, because I think that the message is not there. The message to focus on muscle health is not there for women. So that's what I wish that they would. Push-ups after this roundtable, all of us.
I'm in. So this is such an important point, because we've got this bias against muscle, and yet your lean body mass is one of the best predictors of health span. So in answer to your question, I feel like every single component of health span, we're at a deficit when it comes to women. So cardiovascular health, metabolic health, we know, for instance, that women experience more endothelial damage and downstream consequences of blood sugar that's in the prediabetes range compared to men. There's all these sex differences as well as gender differences that we should be paying attention to. So when you think about some of the drivers of health span in women, which I think of as the period of time that you feel fantastic, possibly able to twerk, you know, for as long as you can, I think of bone health, I think of muscle health, I think of cardiovascular health, metabolic health, I think of sex drive and some of the components related to sexuality. And I especially think about brain health. So women are once again at a great disadvantage Women develop Alzheimer's disease at double the rate as men. We develop autoimmune disease at much higher rates than men. But if we focus on brain health and Alzheimer's disease, we don't really understand why women have such a greater increased risk. Is it related to perimenopause and menopause? Lisa Mosconi, for instance, at Cornell has shown that there's this endophenotype that occurs in women where about 80% of us start to have a decrease in glucose metabolism in the brain. It's known as cerebral hypometabolism. Why is that? What would help? Would a ketogenic diet help? Does estrogen, which is one of the regulators of cerebral metabolism, is it the loss of estrogen? And therefore, in the right candidate, if you're giving hormone therapy, bioidentical hormone therapy, could you prevent it? So there's still so many questions, and I would say every single vertical related to healthspan needs to be addressed for women.
Would you add emotional health to that list as well?
Absolutely. So psychological, emotional health, women have double the rate of depression. We've got higher rates of anxiety, kind of depending on which one you're focused on, higher rates of post-traumatic stress disorder, so definitely psychological and emotional health too.
Absolutely. And we heard you on the Huberman podcast, and you were talking about how the vast majority of women that you see in the clinic are constipated. And I think he asked you why that was, and your answer was the patriarchy. And I think I was drinking seltzer at this time and just practically spit it out. It was fantastic. But I was like, absolutely. So, maybe a question for everyone here might be like, how have you actually seen the patriarchy influence women's health and health span?
Well, I can start with that, since I said that on Huberman. I was being a little flip, but I think it's important to realize that patriarchy is not men. Patriarchy is a system of power over, and women have been experiencing that power over since time began. And so I think it shows up in so many different ways. I would say over the 25 years of taking care of patients, what I see with women is that the way that they respond to stress is different. We know this from the work of, fight flight, as it was studied at Harvard by Walter Cannon. We realize that that doesn't apply so much to women. That women experience much more of a freeze response, more of a fawn response as a way of kind of adapting to power over. Because a woman who's got fight flight, it's not going to turn out very well, right? If you're running from a pursuer, whether that's a tiger or an aggressive person. So I think it's important to realize that women have this baseline level of stress that idles at a higher speed than it does for women, than it does for men. And I think that colors almost every medical condition that I can think of.
Absolutely. So, Dr. Lyle, I'll ask you a question. Cardiovascular disease is often thought of as something that impacts men more so than women, although it is actually the leading cause of death for women in the United States. So what would you want to tell women about their risk for cardiovascular disease?
That's such an important point. I think for decades we've all been taught that the face of cardiovascular disease is a middle-aged white man, and yet it really is the leading cause of death of women across the globe. 1 in 3 women will actually die of heart disease. And there was a really interesting study that was done by the American Heart Association that found that women actually don't know that heart disease is a woman's disease. So in 2009, they asked women to identify what the #1 cause of death was in women, and only 2/3 of women were able to name heart disease as the leading cause of death. But then worse yet, 10 years later, they asked these same women again, and awareness had declined significantly. In 2019, only 44% of women were able to say that heart disease is the #1 cause of death. So I would say at a very basic level, heart disease is a woman's disease, and we still have so much work to do to increase awareness.
I'm curious, what was the other, the number 2?
Yeah, most people thought breast cancer.
Okay.
Yeah. Well, women are fearful of breast cancer, and they've got good reason to be fearful, but it's important that they understand what their risk is, and that cardiometabolic disease is really the top 9.
That's right.
In terms of what we're going to die of.
Yeah. Also, just in general, the idea of opposite sexes is really kind of thrusted upon us. We've internalized it, and just like we kind of divvy up the world into, oh, well, you know, that's a car, that's a boy's toy, and that's a doll, that's a girl's toy. We do that a lot with like every aspect of life, including specific health conditions or specific traits. And so it makes sense in a world where you're dividing up the world into like, you know, this is for boys, this is for girls, that people will do that with heart disease, or they'll do that with other situations. So, yeah.
Yeah, there's kind of 2 points on that I'd love to talk to you about. And first is, we do have this assumption, that many people have this assumption, that sex is a binary. And it is a problem for a tremendous number of reasons, but including in clinical research. I mean, all of the clinical research we have done is either exclusively on males or females, or both, and that binary has been cut. So I think there's a real impact even on the data and the knowledge that we have from clinical studies because of that kind of fallacy that sex is a binary. So actually, as a biologist, can you tell us a little bit about what that fallacy is and what's behind it?
Yeah, so a lot of times when we talk about sex not being binary, there are some people, especially some people online, who will get very mad about that, and they'll think that you're saying that, oh, there's no such thing as sex differences, and that's not at all what it means. It just mostly means that sex is multifaceted and it's variable. So for instance, when we talk about sex, we're not talking about any one thing. We're talking about a collection of different traits. So that could include sex chromosomes, it could include aspects of reproductive systems, it could include what are sometimes called secondary sex characteristics, which are the ones that arise for most people during puberty, where, you know, if you have estrogen in your system, you'll develop breasts. If you have disproportionate amounts of androgens, you'll get facial hair, etc. And so there are all these different traits, and they don't always line up in the same way in people. And there's also some variability to all of them. So for instance, 1% of the population is intersex. That is that some aspects of their sex characteristics don't fall into what's considered standard for male and female. And then also it's pretty well established that biology influences at least 3 different traits that we might think of as behavioral or psychological, which are gender identity, gender expression, and sexual orientation. And those can also vary from one another within the population. And so that's what leads to there being LGBTQ people. And so basically, I think it's just really important to realize that since every single one of these traits is somewhat variable, that's why we get for almost every trait that you look at, it's the overlapping bell curves, that it's not like all the women group here and all the men group here. It's just there are 2 bell curves and there is some overlap, much like the example I often use is height, because that's something that everyone knows. Yeah, if you have a typical male puberty, you're going to be taller than if you had a typical female puberty. But if you look at people in general, you know, there are some people who are 5'8", and that could be a woman, that could be a man, that could be someone who's non-binary. So I think it's really important for us to recognize that diversity when we're talking about people more generally in the social world, but also within health settings as well.
Definitely, and I know that we have a lot of expertise and belief in precision medicine here, and everybody is an individual. It helps when you're able to kind of measure the biology of an individual, so you can make decisions about what is actually going to be beneficial for them. Of course, you know, being able to measure people over time is also incredibly important. And one of the things that we are doing at InsideTracker now is we are measuring more hormones. So I would love for somebody to explain, like I'm 5, what are hormones and how does knowing more about hormone levels in your body help improve your health?
Happy to talk about hormones.
I think you would, yes.
So I think of hormones as text messages that get sent throughout the body, telling often a distant organ what to do. There's local effects, there's distant effects, but hormones really drive what you're interested in. And what's key to understand when it comes to those that are born female and women is that there's so much tumult. So women go through much more dramatic changes related to their hormonal composition. So both males and females go through puberty, trying to be non-binary as I speak into this, and please correct me as I go along. But then when it comes to pregnancy, postpartum, perimenopause, menopause, we go through these dramatic changes where the delta, the change in the slope of hormone production is so much steeper than what you see in those that are born male. So I think it's essential to understand, as you said, in a time series, what's going on with your hormones. I think it's important to have a picture of what you're experiencing. You know, one of the things, I've got 2 younger sisters, and I was asked by them, hey, when should I do a hormone panel? And I said to them, listen, my preference would be that you do it in your 20s or 30s, at the latest in your early 40s. Get a base case, get a baseline of where you are when you feel kind of at your best, so that you could then return to that point later in perimenopause and menopause.
Anybody else measuring hormones in the clinic? And what do you do with them, and what do you recommend to your patients?
Well, we obviously measure hormones in the clinic, and you know, I love what Sara said in terms of where you feel best. So there's the data. It's really important to look at, to be able to drive decisions, but also it's very individual. Where does someone feel great? And I think really shooting for that while keeping everything within safe ranges is important.
Awesome. All right, so one topic that we are very passionate about at InsideTracker is ensuring the accuracy in scientific messaging and upholding scientific integrity. So regarding the role of misinformation and the importance of that in scientific and medical communications, how can we help individuals that do not have a medical or a research background gain access to free, high quality, accurate information about their health? And I would love to pose that question to all of you.
Yeah, I think when I think about misinformation, and that can come in many forms, I think the reason why misinformation sometimes catches on is because it's appealing to one of our kind of underlying biases or certain mindsets that we use as shortcuts to view the world. And one that I think comes up all the time, especially in biology, is we have a tendency to try to project causality onto the world around us, right? If there's A and there's also B and they happen at the same time, we kind of want to say, oh, A must have made B happen, right? And that's a big part of superstitions, comes from that. But I think that comes up all the time with regards to scientific misinformation, where, you know, scientists will find association between A and B, and then the journals report it as there's a link between A and B, and then people understand that as A causes B, right? And another thing that comes up all the time, especially when it comes to like anything that involves genetics or genes or DNA, is that I think people imagine, they know that there's chromosomes and chromosomes have genes, and that's kind of where it ends. And I find that most people think of genes as little light switches that go on and off, right? And so, oh, if you have this gene, it's like, you know, oh, it's the gay gene, or it's this gene, and that turns something on, and if not, it turns it off. And obviously we know that it's way more complicated than that. And so one thing that I often do when I'm giving talks, particularly related to biology, I often really stress to audiences about complex traits, which a lot of people, which are really well accepted within biology, but a lot of people don't really think about that, you know, any given trait or condition is going to have a lot of different inputs, a lot of different biological molecules interacting together. And sometimes using the light switch analogy, I'll say to people, imagine that you're in a room and there are 20 different light switches, right? And so maybe me turning this light switch on, it comes a little lighter, or maybe it gets a little darker, but that's like one contributor to this much larger thing. And I think that sometimes helps people get out of the tendency to put that kind of causation on, oh, this one factor must be causing this like much larger, broader condition.
Absolutely. I think I always joke that if I could get a tattoo, it would say mice are not humans and correlation does not equal causation. And yeah, I agree. Everybody really wants a very simple answer to very complex things that everybody here has very specific expertise in. So that's great. So let's talk about different ways that we can be actionable about our health. So I would ask, what are some examples of things that women might do differently after, let's say, having their hormone levels measured, or other like critical biomarkers for their health span?
Well, I think nutrition is a fundamental piece to all of this. When we think about when we're younger, we're really driven by hormones. And as we age, there's certain mechanisms that change. Particularly when we think about body composition, skeletal muscle is less driven by hormones, and it becomes, let me say it this way, the skeletal muscle becomes less efficient. So its ability to sense nutrients like dietary protein, amino acids, in particular some of these branch chains, decreases. So when an individual is younger, to get to kind of specifics and that's helpful for the individual, you can stimulate skeletal muscle 5 to 10 grams. When you're a younger child, it's much easier. As we age and that balance shifts less towards hormone and growing up, we have to rely more heavily on nutrition. So dietary protein is key for muscle health, in particular to overcome some of these challenges of aging, which is anabolic resistance. And so that becomes really critical.
It is critical. Your conversation makes me want to make a smoothie right now, have some amino acids, so I really appreciate that.
Afterwards. After we twerk and do all
Right
of
there, there we go.
Yeah.
Yeah, so I would maybe come a little broader. And what I talk to about with my patients about after they get a hormone panel is there's so much that we can change and improve with your hormone panel, with the way that you eat, move, think, feel, and supplement. So I think of those as a foundation for addressing hormones. I'm not someone who goes straight to a pharmaceutical to address, insulin with metformin or low testosterone with topping them off with testosterone. I like to think about, okay, how can we change the way that you're eating? So say you've got a problem with estrogen or with insulin. Let's take insulin as an example. We know that within 48 hours, you can start to change the insulin signal just with your fork, just with the food that you're putting on your plate. So I think that is so empowering to realize that much of your hormonal balance is modifiable with lifestyle medicine.
Can you actually define hormonal balance for us? Because that's always a tricky one. But
yeah, I think of hormonal balance as almost a Goldilocks position with the hormones that are the most central. So in women, I think of cortisol, estrogen, thyroid, testosterone, insulin. So hormonal balance is where those hormones are not too low and not too high. So with testosterone as an example, if you're a woman who's, say, 48 years young, and you've got a low testosterone level, it's going to affect your ability to maintain your muscle mass. It's going to affect your agency. It's going to affect your confidence. It's probably going to affect your libido. It might also affect vaginal dryness. If you're a woman in her 40s with high testosterone on the androgenic side, the phenotype is usually polycystic ovary syndrome, you're at greater risk of cardiovascular disease. So that androgen level is one of the best predictors of your future risk of cardiovascular disease. So by hormonal balance, I mean you've got these hormones each in the right position, not too low, not too high.
And is that individual for every person, I imagine?
Well,
how do you decide what that balance needs to look like?
We've got reference ranges from these overlapping bell curves, which I think is such an important point. But then you also want to personalize, because there are some people who had high-ish testosterone most of their life, and so when they're in the lower half of the normal range with their testosterone, they might feel symptoms. So you use the bell curves, but then you also apply a level of personalization.
Okay, so we talked a little bit about the role that hormones can play in cardiovascular disease. So I'd love to ask you, Dr. Lau, about some of the more important health screenings or tests that women should have for their cardiac health, and at what ages they should have them.
Yeah, it's a great question. We think, as a cardiologist, I largely see individuals who already have existing cardiovascular disease, but I think an important role that we have is to think about how we can prevent patients from developing heart disease. And so, I think that this is preventive cardiology is an area that is growing. And the things that we often will think about screening patients for are things like their cholesterol levels, what are their blood pressure, what is their hemoglobin A1C, which is a marker of one's sugar control over the past 3 months. These are all like hypertension, high cholesterol, diabetes, prediabetes are all important risk factors for the development of heart disease. And getting all of this information together with other things like what is a patient's age, what is their, it's very binary when we think about these risk calculators, but we think about, are they a man, are they a woman? Do they also smoke? Those sorts of risk factors, we sort of put them all together, and we currently, although imperfect, use something called an ASCVD risk calculator that gives us an estimate of what somebody's risk of developing heart disease will be like in 10 years. And based on that estimate, we have conversations about, lifestyle interventions. Is it time to think about starting a cholesterol medication? Things like that.
Actually, if you wouldn't mind, could you talk a little bit about the importance of measuring ApoB, because that's something new that we just added to our ultimate panel.
Yeah, there's a lot of interest in understanding folks' apolipoprotein B level. It's definitely a marker of risk if somebody has high levels of ApoB, but the issue right now is that there's no treatment for that we can't lower apolipoprotein B. Now, there are many drug therapies that are under clinical trial presently to try to answer that question, that if we can directly lower ApoB, can we actually improve cardiovascular risk? But I think what it helps us do is we consider it to be a risk-enhancing factor. So we look at all the traditional risk factors, like I just mentioned, sort of the typical cholesterol panel, high blood pressure, smoking, diabetes, et cetera. And then you get sort of an estimated risk of developing heart disease. And then we look at if you have other risk-enhancing factors. An elevated ApoB is one of those risk-enhancing factors. And that might sway your decision to maybe start somebody on a cholesterol medication when you otherwise maybe wouldn't have. So that's really the role that we, right now, currently with the level of evidence that we have, that's how we've been thinking about ApoB in the practice.
Awesome. So we'll also be adding estradiol, progesterone, and TSH to our panel. So I don't know if those are also biomarkers, I'm sure, that do get measured in the clinic. So I would love if you all could talk about how those are applicable to the women that come to your clinic and how do you use them?
Well, I heard TSH, right?
Yep.
Is that what you said? Yep. So thyroid-stimulating hormone, the brain connection to the thyroid. I would say, and typically that's the first thing that individuals screen for thyroid health. That, and in addition to that, you would think about thyroid antibodies, but in and of itself, it's a great screening tool to tell if someone is hypothyroid, if someone is hyperthyroid, and it's very actionable. And of course, looking at free T3, free T4. I don't know if you look at reverse T3 as well.
I do, as a measure of stress and as a blocker for the thyroid receptor.
Yeah.
So I totally agree. And, we've got such an epidemic right now of Hashimoto's thyroiditis that I think the antibody piece is incredibly important. We've got this background of thyropause. So we know about menopause, we know about perimenopause. There's this experience of women as they get older of their thyroid just not working the way that it once did. And the vast majority of that, I think 90 to 95%, is related to autoimmune attack. So being able to track that, knowing ideally what your TSH was in your 20s and 30s, and then being able to track that over time, having a time series is really essential, which is something we do in precision medicine, to do these deep time series. The other hormones are essential as well. Estrogen doesn't change until pretty late in perimenopause. It can also fluctuate wildly. So knowing where you are, not a single measurement, but a time series can really be helpful. And progesterone, one of the things that I see a lot in my patients is that they have low progesterone starting at 35. So that can be related to a number of different causes. Sometimes it's just ovarian aging. Sometimes it's related to having high cortisol, which I see in most female physicians. It's a very common
Why would that
problem.
be? Just
I have
kidding.
no idea. No idea. So I think being able to track these over time is essential.
So we want to talk a little bit about muscles, which we know is a great topic. So you are a big proponent of strength and resistance training for women, and we love you for that. How do estradiol levels contribute to declines in muscle mass, and what is the real impact of that for folks?
I think that there is more evidence emerging. So I would say that there are anabolic components to estrogen and skeletal muscle. Oftentimes we think about testosterone as a more anabolic impact on skeletal muscle. But what we do see is when estrogen levels decline, there is signaling within skeletal muscle. So we do see, which by the way, can be overcome with exercise. A decrease, it's interesting, skeletal muscle, the input into skeletal muscle is multifactorial. It's not just hormones, it's not just training, it's not just nutrition, it's a combination of all of these things: physical stress, hormonal stress, energy input, and but with a decrease in hormones, a decrease in estrogen, there is impact on skeletal muscle. To the magnitude, I am not sure as it relates to the data yet. I think that we still need to get a more totality, a bigger body of evidence. But on the positive note, when individuals' estrogens decline, that is not a death sentence for body composition. Is it more challenging? Certainly, oftentimes we see with a decrease in estrogen that there's decreased spontaneous movement. But again, these things can be overcome.
Mm-hmm. And in terms of resistance training and women, I think you mentioned it earlier, there being this myth out there that women may not want to perform as much strength training or lift heavy weights because they're afraid of getting bulky.
Everyone here has heard that. Haven't you heard that? You've heard it. You guys have all heard it.
Yeah.
They are afraid to look like Arnold Schwarzenegger.
And it's funny because it's like, isn't it kind of hard to do that? I mean, you don't just do like a couple CrossFit sessions.
And I mean, yeah, it's hard.
Yes.
And it's a total myth. Women can be strong, you can be physically fit. I think that we've all experienced it. And it's interesting. So in the beginning of this conversation, you talked about longevity, you talked about health span. Nothing is going to be more critical, in my opinion, than your ability to maintain your own activities of daily living.
Absolutely.
Critical. So whether you have heart disease or thyroid disease, any of these other things, you want to be able to get up from the toilet. Mm-hmm. You want to be able to get out of bed. Skeletal muscle is the only way that that's going to happen. And it is critical. How do you maintain the strength of skeletal muscle? You do need to do exercise. Is walking enough? It was interesting, you're talking about insulin and how, you can impact insulin almost immediately. Getting up and moving increases insulin sensitivity. That fast. But again, skeletal muscle health is critical. It is the foundation. It's the pinnacle. You have to do it. You have to execute. So whether that is going to the gym, if you don't want to go to the gym, you can do a series of body weight exercises that, you do have to elicit some, I don't want to say pain because that's not true, but it's fun.
It's hot. It's hot.
Yeah.
Muscles are hot.
Right? You do have to put in a certain amount of effort. Mm-hmm. There has to be effortful training.
There has to be resistance in order to build. There has to be a stimulus, we'll put it that way, right?
And it doesn't get easier.
Yeah.
The time to do it, you asked in the beginning, what is the one thing that you wish everyone knew? The one thing I wish everyone knew is maintain your skeletal muscle health.
And actually for women that are, approaching real changes in their lifetime, let's say around menopause, I think that's about the time where sarcopenia becomes an issue, where, basically a loss of bone and muscle health. So is there a period of time where you actually really have to build up your reserves of muscle health? And around what time is that? Like, when should people be preparing for tapping into those reserves?
I think that this is a critical conversation. You mentioned sarcopenia. So sarcopenia, if we can just define it, is loss of muscle mass and strength. oftentimes we think about sarcopenia, and we've all seen our aging parents, we've all seen, older individuals that got smaller. And we're like, dude, what happened to Joan over there? That is what we typically think about sarcopenia. I don't actually believe that it's a disease of aging. Mm-hmm. I believe it's a disease of inactivity. And it could begin decades before, just like cardiovascular disease, just like Alzheimer's disease. So we now recognize that these diseases of, quote, aging actually begin in our 30s. I don't think sarcopenia is any different. Mm-hmm. We know that there is no such thing as an unhealthy sedentary person. There is no such thing, as a healthy sedentary person. So when you look at the literature and they compare these groups of healthy sedentary to whatever, that in and of itself is a diseased model. There's no such thing as a healthy sedentary group.
It's such a good point. I feel like your muscle health is as close to a panacea as we have when it comes to healthspan. Because, I would say it's up there with sleep. Because it's so essential to, this idea of activities of daily living. Like my bar is so much higher in terms of what I want my health span to look like. And I want to have the best glucose disposal that I can possibly have. And I want that for, every single patient I take care of. And that's where movement is just so essential.
Critical, because we know that skeletal muscle is responsible for 80+% of glucose disposal. Mm-hmm. When we care about diabetes, we care about these things of metabolic dysregulation, we have to look at skeletal muscle as the primary point.
And if we actually talk about metabolic dysregulation, what does that look like throughout a woman's lifespan? And what should we be cognizant of as we go from our 20s to our 30s to our 40s in terms of metabolic dysregulation?
There was a study at the University of North Carolina showing that 88% of Americans are metabolically unhealthy, that they have at least one criteria for metabolic syndrome. So we are in a crisis, a metabolic crisis. And the data are not as firm when it comes to women, but it seems like women may be at greater risk. So I think what's key is to not outsource your metabolic health to your clinician, to understand that in your 20s and 30s and 40s and as you get older, that you have to take this on. You have to eat the right foods that are the right fit for you, mostly vegetables, a little less of the processed food and the other things that we know can cause so much dysregulation. I'm not a big fan of breakfast, lunch, and dinner and snacks in between. I think you need periods of metabolic rest. Intermittent fasting is something that 95% of us can do. Combining that with having the kind of movement in your life, the kind of exercise, lifting heavy, I think is essential. So really figuring out how does that become a priority? Because 99% of the time with your health, it's not spent in the doctor's office. Like a tiny little fraction is in the doctor's office. Mm-hmm. So take it on yourself and realize what's going to work for you as you get older.
Yeah, that's great. And it kind of brings up another topic where you're all very busy, accomplished women, and we would love to hear about what your own kind of personal strategies are to mitigate stress in your own lives. So maybe I'll start with you, Julia.
Yeah, stress is something that I wish I kind of was a little bit more aware of when I was younger, partially in ways that some of us experience, for instance, being in academia and graduate school and doing a postdoc and however many hour-long days. And then also the issue of stress, it's very well established, the model of minority stress, mm-hmm. that just living in a world, if you're part of a group, that you always either are feel on the defensive or always trying to navigate around other people, that some of that gets internalized, that can create a lot of stress. So yeah, that's been something that I've found myself personally working on. I have tried meditation, and that's something that I personally find difficult to turn the sounds off in my brain, and I know other people that I know like find it really important for them. One thing that I really do try to make a point of, with exceptions of like if I have an immediate deadline, an important deadline, or if I am flying across the country, for instance, I really make a point to try to get a full, 8 hours of sleep every night, to give myself that space. And I also give myself space at the end of the day where I kind of like, okay, I'm done with this. I can relax now. And maybe that's in the middle of the day. Maybe in the middle of the day, I'm going for a walk and maybe I am doing a little bit of work at night, but just giving myself space every day so that I can not have that weight and that stress on me.
Yeah, all of those are really great points. And it made me think of my daughter, actually, who she's always rocked to self-soothe. And we've noticed that it bothers other people, right? It bothers the people around her, but it doesn't bother her. And in fact, it is a coping strategy for her to deal with a stressful situation or when she's tired. And I have watched her learn to almost constrict that and hide that. And I've watched the energy that it takes for her to try not to rock around other people just because it makes them uncomfortable. And it bums me out, honestly. Like, it totally bums me out. And I had a conversation with her and I said, okay, well, if it's bothering the driver of a car, then maybe, okay, you can spend the energy then. But if you're at school and it's really harming nobody, then why do you have to spend all of that extra energy to suppress something that is going to calm you down so you can perform and be comfortable and in a way that's at your own best? And so she's actually learning to have those conversations. And obviously that is a tiny example that can be expanded to so many other things beyond, rocking to self-soothe. So I think that's great. I love that you give yourself 8 hours. I think Matthew Walker says this too. He says, I give myself 8 hours to try and get my sleep. If I don't get it in there, I try not to stress out too much. But I personally love meditation, but I would actually argue that meditation for me is noticing the absolute frenetic mess that is my brain and actually trying to parse out what it is. Just try and watch it and notice it. But I would say I'm not necessarily calmer after I meditate at all. That's not an impact. But how about you?
Yeah, I think you make a good point, which is to say that everybody deals with stress in different ways. Mindfulness training has been something that I prescribe to my patients after heart attacks, for example, but it works for some people and it doesn't work for others. And I would say for me, just having a really strong support system, my family, my husband, my colleagues at work, my friends, really help to ground me. There's always stressors. There's been so much discussion in the healthcare field now about burnout. I think that that's a really big issue that we're seeing all the time, particularly in the wake of the COVID pandemic. And so I think it's important to give one space to have time for oneself. But for me, it really has been having the connections with the people who really care about you, independent of your professional accomplishments and things like that.
Yeah, that's great. And I feel like there's finally more recognition about the need for social support and that network as a component of your health. It's not just your endurance training and your resistance training, but also did you make sure that you made eye contact with somebody that you love and who loves you today, or the cat, or whatever it is, but something that brings you some joy. So we'd love to hear about what you do.
I love crafting a la carte menu for my patients of things that really help them with navigating stress, because stress is inevitable. And what works for me are yoga, meditation, sex, orgasm, working out. Those tend to be the most effective, although one of the things I've realized, especially in the past 10 years, is the role of trauma in stress and how trauma is often at the root of our stress response, especially a more dysregulated stress response. And so we're in this era of more trauma-informed treatment, trauma-informed therapy, psychedelic medicine, and I think those are really interesting areas, especially when you look at the effect, for instance, from the phase 3 randomized trials looking at MDMA for post-traumatic stress disorder, has durable effects, like somewhere around 2/3 to 80% of people no longer meet criteria for PTSD. So lots of new treatments on the horizon. I would say these healing states of consciousness that you can get into with yoga, meditation, psychedelics, orgasm, those are really beneficial for us with regard to stress response.
All makes sense. I'm also very excited about some of the psychedelic therapies that are definitely getting more attention now. Awesome. How about you?
So I've thought a lot about stress, and from my perspective, really reframing what stress is in terms of, it is an opportunity to make us more resilient. So there's this kind of pervasive discussion about how stress is bad. And I do think that there are certain stressors, death, divorce, health, issue, that's some serious stress. But everything else, we are designed to be resilient. We are designed, to me, it's not about getting in a warm bubble bath after a quote hard day. It's, was this day really hard or not? Because the chances are it wasn't really that hard. It was our perception or the way that we're, like our voice micromanaging, whatever it is, it's not a hard day. Going to war is hard. Getting divorced, having a death in the family, these things, those are hard. So really reframing, number one, and understanding that stress is not bad, that it allows us to become better, that there are other stress responses above and beyond fight or flight. I think Stanford, her name was Dr. Kelly McGonigal, talked a lot about tend and befriend and the courage response. There are these other ways. So for me, the first thing that I do is ask myself, is this true? Am I really stressed? Mm-hmm. Is this thing stressful? Mm-hmm. Most likely it's not.
Yep.
And then if that doesn't work, I always recognize that everything in life has seasons, that, this could potentially be a season. So intellectualizing it. And then if that doesn't work, a really good high intensity training interval will work. The kind where you're just completely laid out because you legitimately cannot do anything else. You can't think about it. There's nothing else you can do. You're probably going to go puke in a can, and that's it. And you would be shocked at how much better your mindset is after that.
Definitely agree. I used to go rock climbing because I would be afraid of falling, and so I couldn't really think about anything else when I was trying to not fall.
See, that's genius.
No, it was absolutely mind distracting, and honestly, I often ask myself the question, would I care about this on my deathbed, yes or no, if I'm really just in a spiral. Okay, so actually we'd love to talk about menopause for a little while. Shifting to that, what are some of the most common or bothersome symptoms that women experience before and after the menopause transition? Or actually when people have major changes in hormone therapy, because a lot of those symptoms overlap. So what are some actionable steps that people can take to manage those symptoms? What are the symptoms, how are people dealing with them? Both maybe from a lifestyle perspective, or when do you decide that medical treatment would be beneficial?
Well, there's more than 100 symptoms
of
perimenopause and menopause.
I would
so I'll
say
just
pick the most common and bothersome that you hear.
So the most common are hot flashes and night sweats, vasomotor symptoms. And one of the things we're realizing right now is that vasomotor symptoms are not just a nuisance to be medicated or treated with lifestyle medicine. They are a biomarker of probably damage to the endothelium of your blood vessels if they're untreated. So we're really shifting in the way that we think about some of these symptoms. Other symptoms include mood changes, typically depression, more anxiety related to the estrogen receptor and its functioning, loss of libido, hair loss, breast changes, metabolic changes. So typically as you get older, over the age of 40, you lose about 5 pounds of muscle, you gain about 5 pounds of fat, unless you're doing everything that this amazing doctor recommends. There's osteoporosis, there's loss of the integrity of the the vulvovaginal system, so you can start to have urinary incontinence. So more than 100 symptoms. I think those are some of the highlights. And then I always start with lifestyle medicine. So I start with nutritional treatment, filling any micronutrient gaps. Then I move on to herbal therapies to address, for instance, decreased libido has been shown to be helped by maca in a randomized trial. And then if those don't work, typically it takes 6 weeks for your hormones to reach a new steady state. Then if a woman is a good candidate for hormone therapy, I'll consider bioidentical hormones.
I would say that my strategy is not dissimilar to yours. I may move to hormone treatment, quicker. And I always think about if an individual is really suffering, and I'm sure you feel the same way, then I tend to be more aggressive. So the treatment has to match the symptoms. Lifestyle is of course critical. Very similar.
My job as a cardiologist is to help us determine the cardiovascular safety of hormone therapy. I certainly am not the person prescribing hormone therapy, but really there was a period of time, and we talked about this earlier, where almost every woman was on hormone therapy, and we didn't know what the effects were. And then there was a large randomized trial done in the early 2000s called the Women's Health Initiative that actually showed that hormone therapy did not reduce cardiovascular events, and even there was a signal for harm. Now, I think, so then the pendulum swung all the way the other way, and then now there have been some subsequent randomized trials that have looked at sort of more subclinical cardiovascular disease, and it does look like hormone therapy appears to be safe in younger postmenopausal women who are less than 65, less than 10 years postmenopause. And so my job, I think, as a cardiologist is because there's been a whole generation of doctors who basically say absolutely no hormone therapy for anybody. And my job is to say, well, if you've had a heart attack, well, I don't think hormone therapy is right for you. If you've had a blood clot in your lungs, it's really not safe. But if you have intolerable symptoms of menopause, these are really important symptoms. They really are life-changing. They really reduce one's quality of life. And if you are a reasonable candidate, if it's safe for you, then it can be done safely. So I think that's my role as a cardiologist.
Awesome. I'll ask you guys two questions, and this one is actually one of my favorites. What is one thing that you wish that you actually knew about your health in your 20s? And if you could go talk to that person right now, what would you tell them?
Mine's sort of easy but complicated in that I wish I knew about gender affirmative care. Mm-hmm. But at the same time, when I was in my early 20s, that was the early 90s, and it was not a very good time to be a trans person. It was very difficult to find out anything about trans communities, and at the time there was a lot of really strict criteria, often very arbitrary criteria, like criteria that, we're not going to give you hormones unless we know you'll pass as a woman and that you'll be a heterosexual woman, and a lot of criteria now that are very problematic. That wouldn't have done me as much good as it could have. A good thing is now that there's actually a lot more availability of that information and resources, and also particularly a lot of people doing gender affirmative care understand that there's a large diversity of people who are trans, mm-hmm. and that there isn't necessarily, it's, this one path, you're starting here, you're going to end up here, and we're giving you exactly this, and you're going to end up in this mm-hmm. particular outcome. Important understanding that for some trans people want to transition. Some people are actually happy with low dose hormone therapy. Mm-hmm. Some people will maybe do certain interventions and not others. And this isn't universal yet, but it's something that's getting a little bit better, and is definitely better from where things were back then.
Yes, thank goodness, and hopefully it continues to get even better.
Yeah, I mean, we'll see with our current political environment. I feel like it's getting better some places and getting worse other places, but that's its own conversation.
I fully agree. Yeah. Fully agree. What would you tell your 20-year-old self?
Well, one of the things that I think has been really interesting that we've discovered recently in the cardiovascular space is that pregnancy complications, so adverse pregnancy outcomes, are actually associated with later life cardiovascular disease. And nobody previously had ever thought, like, if you maybe had preeclampsia, for example, if you had gestational diabetes, your risk of heart disease later in life, many years after you've had the pregnancy, is actually quite elevated. None of us were really thinking about this relationship. And most women get pregnant in their 20s, 30s, sometimes 40s, and that's not a time people are really thinking about their cardiometabolic health. And so certainly one of the things that I really advocate for now is that all patients, when they're coming in for a cardiovascular risk assessment, we should be asking them a reproductive history. Like, did you have difficulty getting pregnant? Infertility, we know, is associated with greater risk of cardiovascular disease and later life heart failure, for example. Did you have preeclampsia during your pregnancy? Did you have a miscarriage? All of these things actually are risk-enhancing factors for heart disease, and we never really thought about them before, and we really don't do a good job asking our women patients anything about their reproductive history.
That's a great point.
Yeah, in my 20s were basically clinical training. So that was medical school and then residency at UCSF. And so I would say that I wish I had known more about navigating stress. I also wish I knew more about trauma then, because I think that can make such a big difference in terms of the relationships that you get into, the way that you connect with other people. Even the way that you define purpose and meaning can be changed. There's also the biological effects of, aggressive stress response, grinding your telomeres down to little nubbins, and just accelerating the aging process so that your biological age is not quite matched or, better than your chronological age the way that you might want. So I would say navigating stress would be the biggest thing I wish my younger self knew.
I think that I wish I had understood nutrition better when I was in my 20s. At that time I wanted to do everything right, and it really became this obsessive focus of what do I need to do so that I can feel better and feel my best, and it really consumed a lot of my time trying to search for the perfect organic macrobiotic meal, and I didn't feel great. So that's definitely a primary thing. And then the other thing is how to have more stress resiliency. So very similar to what your experience was, to be able to navigate the input. Because again, there's medical school, there are all kinds of things, involved in training. And when you're in your 20s, what do we know? We know as we get older, but the amount of pressure and the drive to make a contribution to, whatever it is that an individual feels meaningful, particularly myself, there's a certain amount of pressure with that. And had I been able to reinterpret that, maybe I would have slept more, or I don't know, played with my dog more or something. Those two things.
Which might be two things to help mitigate the
turtles.
Stress response.
Or turtles.
Or turtles, right? Turtles are lovely. I bet you could really calm yourself down by watching a turtle. But I think all of that is great. And in my 20s, I certainly was not thinking about my health span at all, really. I was just kind of having a great time and trying to get through life and school and everything. And then later on, you find that it does have these impacts on things like your cardiac health. So, we would love to tell the folks that are listening now, they might be wondering, what can they do right now to take a small step towards improving their health? And actually, I think that that's a little important too, to talk about is, we see a lot of different protocols out there, a lot of different advice and directions that people can go in terms of to mitigate their stress response, to sleep well, to eat better, to make sure that they're doing all of the right exercise, and that in and of itself is super stressful, right? So one thing that I think about is I honestly try to be proud of myself for doing one tiny thing that day, and that might be not having an extra glass of wine. It might be having, one meal where I get a little bit more protein, because I tend to, eat zero protein whatsoever. I'm a disaster.
There's a fix for that.
Eating more protein?
Yeah.
No, but I think I would love for us to be able to tell people, what are some of these small, tiny things that they can do to just make small improvements and to stress out about it less, but still keep marching in the right direction.
Yeah, I'll start. One thing that I see a lot is that people wait for the perfect time to start exercising, or wait till they're motivated. You're never going to be motivated. There's never going to be a perfect time. And, I feel that when individuals are not acting, it just creates distraction. Mm-hmm. You have to move. I don't care. Go for a walk. There's no reason not to move. If you think that you don't have time for it now, can you imagine what's going to happen from the repercussions of not moving? So don't need the perfect program. You could do some push-ups. And if you can't, you can do a modified version or get out and walk, move.
Can you squeeze these things into maybe one set? Or, if you can't get outside and you literally have 2 minutes before your next meeting, what can you do?
I was in my hotel room this morning doing push-ups.
Perfect.
So if you, either you're going to find an excuse or you're going to find a way. And it's not that hard to find a way. So don't wait for the perfect time. You need to move.
Okay. So if you can't get in 45 minutes, but you can get in 2 is better than none.
I guarantee you give me 2 minutes, I will get you gassed.
Yeah.
Give me 2 minutes.
Beautiful, beautiful.
I did a 2-minute plank this morning. I was channeling you. So I love this point because I think that these baby steps, these small defined steps, add up to major transformation over time. And so one of the things I start with my patients is measurement. Because what you measure improves. It kicks off the time series. It's a way of looking at, okay, where am I? All of us have a few vulnerabilities that we need to address. And I can think of like 1 or 2 patients that are the exception out of the 25,000 that I've seen. And so when you identify those vulnerabilities and you say, okay, my insulin is a little high, it's 10, it's not at 6 where I want it to be. Let me address that. Maybe it starts with intermittent fasting. So what you measure improves. Start with measurement.
Mm-hmm. And do you actually find, this is a topic I'm a little obsessed with too, between the triad of recovery, exercise, and nutrition, some of these things are easier for folks than others. And I feel like it's maybe better to start with the things that are easier for folks and then kind of figure out that one pillar and then move on. Do you guys agree with that? At least that's what's been true in my own life. Like, exercise is easy, nutrition is hard. So I start with exercise. But eventually, if I don't fix my nutrition, my exercise suffers. So then that motivates me to fix nutrition. But if that makes sense.
I think that's key. I think it's part of personalization. And when you have an easy win, if exercise is easy for you and you start there, that then creates this cycle of benevolence that allows you to take on the more difficult things. But the other piece too is that a lot of this is genetically determined. Your recovery, for instance, about 40% of your recovery is determined by your genetics. So it may be that something like recovery is hard because you inherited genes that just make you take 48 hours to recover from a workout with Dr. Lyon.
And how about you?
I guess I would just add to this great discussion by, one thing I frequently tell my patients is try to incorporate it into your daily life. Like, I think when you think of something like a workout as work, you're never going to do it. And, people are always waiting, just as you say, like for that perfect time. But instead of taking the elevator at work, why don't you take the stairs? Simple things like that. At lunch, walk around the parking lot instead of, sitting in front of your computer. So these are the just simple things that I recommend to patients, all of my patients, from my prevention patients to patients who've just had a heart attack. Really, and I think that these small steps ultimately, just as you say, really amount to real transformational change.
Mm-hmm. And how about you? What would you tell women so they can take control of their own health?
I think most of the things I would say kind of echo things that all you said. I mean, I'm a very big believer of if you don't like something, like if you don't like jogging, don't jog. There are other things that you can do that you will probably like, and maybe you'll really enjoy swimming, maybe you'll enjoy something else, right? And I think that that's an important strategy for me in life, that if there's some things that you really don't want to do, but people are telling you should do it, as long as you're making up for it in some other areas, as you were trying to echo, I think that that's an important thing. And also the just kind of one thing at a time, one step at a time. Don't try to be like, okay, I'm changing my whole life right now at this moment, because if you bite off more than you can chew, that will be a possibility of failure. Whereas if you get that one task done and it's like, oh, I got that done, let me do this one now.
Yep.
So yeah.
Yep. Awesome. Wonderful. So I think that we are ready to wrap up here. We've come upon our time. I really want to thank every single one of you for coming here and being part of this incredible discussion. I have learned a ton. I hope that our audience has as well. And we are just psyched. We're psyched to have you. So thank you so much.